Otherwise, basically the other treatment's the same. So that's why it's important to recognize it's again an inferior STEMI, and another common complication associated with it, the third degree AV block. The P waves are going on its own, and QRX complexes are going on its own. So again, it's an inferior STEMI with posterior extension and reciprocal changes complicated with third degree AV block. So just to reiterate, so if you see a inferior STEMI in a first traditional ECG, most of you do actually anyway. So try to take a complete ECG to look for the complications. So when you order the subsequent ECG, order it with the posterior leads and the right-sided leads as well. Right. So we will move on to the next territory. Again, it's anterior STEMI. So you see ST elevations in. So it starts here from one AVL as well. So it's basically an extensive anterior STEMI. And because it involves the high lateral leads, you could see the reciprocal changes as well here. So again, another anterior STEMI. This is called a tombstone ST elevation with just for more political things, but anyway, the management is same. So tombstone ST elevations in the again the anterolateral leads and the reciprocal changes. If you carefully look in the AVF and tree, there are some on top of it. There are some occasional LV epicardial origin ventricular ectopics. Right. This is another territory again, just pure high lateral STEMI and reciprocal changes in the inferior leads. And right, so again, this is an inferolateral with the posterior extension. So lateral STEMIs can be associated with inferior and vice versa. So again, this is a inferolateral STEMI with posterior extension. Right. So I don't know if it is your mindset or my mindset. So it's going to be over anyway. Right. Right. So we will move on to the high risk ECGs. Now the STEMIs are over. So everyone knows Valence. So this is type 1 and type 2. So it is easy to spot these T wave abnormalities, but you should make sure it's Valence. So if you see this pattern without any R wave, so if you see a Q and this pattern, it's not Valence, it's a previous STEMI, right? It's a recent or an old STEMI. So don't make a diagnosis of Valence if you don't see any R waves, right? Then the next thing is there won't be any significant ST elevations if it's a Valence syndrome. The third thing is the troponin. So usually the troponin is normal. If you have a high sensitivity troponin, it may be marginally elevated. So Valence don't give very high troponin. So if you have this abnormality and very high troponin, then it's something else, right? Then the fourth thing, we have the luxury of doing an echo, and we could see some wall motion abnormalities associated with Valence, right? And the other important thing, so Valence ECGs appear when the patient is symptom free. So the Valence ECGs appear when the patient doesn't have any chest pain, right? So when the patient develops a chest pain, it normalizes. It falsely normalizes actually. So the Valence ECG, then when the patient have chest pain, it normalizes. Then it becomes Valence again. So it's very easy to miss a Valence when the patient comes with chest pain. You do a normal troponin and you do a no ECG. ECG looks normal, troponin negative. You can easily miss that. So always do an ECG when the patient presents with a classical chest pain, right? So repeat the ECG if the patient comes with a classical chest pain once the chest pain is over. Right. So again, another high risk ECG. So Valence is, it's an indication for earliest possible PCI, and likewise, this is another indication for an earliest possible PCI. So you can see ST elevation in AVR and V1. Then there are ST depressions widespread. Usually, at least there will be ST depressions in 8 leads, right? So this is called a left main equivalent ECG because it does not always indicate that there's a left main obstruction. So sometimes some studies say if the V1 ST elevation is more than AVR, it's more towards the proximal LAD. But anyway, the management is same, so it's an early PCI. Sometimes a patient with triple vessel disease can present with this kind of ECG. And there are some rare coronary anatomies like a wraparound LAD, and those things can again present with this type of ECG. If a patient, there are some rare cases, you can see some anterior ST elevation as and inferior ST elevation. So these kind of ECGs, it's very rare for a plaque to rupture at the same time of the LAD and RCA. So if you see an infarction or ST elevations in anterior as well as inferior tertiaries, it's mostly the wraparound LAD, which means, the LAD comes in the anterior interventricular groove, and sometimes it goes beyond the apex and runs in the posterior interventricular groove, giving the posterior PDS as well. So if that LAD is gone, then it infarcts the anterior as well as the inferior tertiary. So which is a bit of a less common anatomic variant. Right. So this is a very important ECG, and it's very easy to miss this, right? So this is, if you can closely observe, there's an upsloping ST elevations in the anterior leads. Mainly it's V2, V3, and there's total tentative. So this is a D Winters ECG, and this is a STEMI equivalent. So if this ECG is there, it means your LAD is completely excluded. So this may precede or follow a frank ST elevation. So what happens next is sometimes this pseudo normalizes without going into an ST elevation. So again, you can miss this if you don't look at this ECG carefully. So this is kind of a new entity, and the Western world have abolished completely, almost completely, the thrombolysis. So they do primary PCIs for all the patients. So this is an indication for primary PCI, but for thrombolysis, we don't have enough evidence because it's kind of a new entity. So, considering our available facilities, I would suggest to thrombolyze if you see an ECG like this. Right. So another difficult diagnosis to make is if the patient have left bundle branch block. So, sorry. So this is where the old ECGs play a major part. So if you have a normal ECG recently taken, patient comes with a classical chest pain, and if you see a left bundle, then you know for sure this is STEMI equal, and you could thrombolize without any hesitation. But if you don't have an old ECG, then you are in trouble, because this Sgarbosa criteria is not very sensitive and or specific as well. Rather than relying, rather than depending on this criteria to make a diagnosis, in case you will miss most of the actual STEMIs, um, you could the rare study says it's more sensitive to make a ratio of the ST elevation to the S wave. Then if it is more than 0.25 in any lead, then that means um, it's an acute event rather than an old left bundle branch block. Right. So otherwise, in basic, if you see concordant ST elevation or concordant ST depression, it suggests a new ischemia. Right. So always please preserve the previous ECGs. Right. Again, so if a patient with classic chest pain comes with this left bundle branch block, you don't have previous ECGs, then you are in a hesitation, because if it is primary PCI, then it's straightforward. You can take to the lab, and if you don't see a lesion, that's fine. Okay, I made wrong diagnosis, no consequence. But if you thrombolize for a false positive, this one, and if the patient get complication, then that's a concern, right? So that's why please preserve the old ECGs again.